Welcome to Louisville Lectures Pediatric Emergency Medicine Lecture Series.
Hi everyone, I'm Jenny Hockenbury, one of the Pediatric Emergency Medicine Fellows. Today we're going to talk about the FAST exam in pediatric trauma. Our goal is to understand what we're looking for, how to obtain the views, and how to interpret them in the trauma bay. The exam stands for Focused Assessment with Sonography for Trauma. This is a rapid bedside ultrasound used during trauma resuscitation to look for free fluid, usually blood, in the abdomen or chest. In pediatrics, we use it to help triage and guide our next steps, but it's important to remember that FAST is not perfect in children. The exam can be performed simultaneously with nearly all aspects of trauma management, including physical examination, resuscitation, and procedures. The FAST helps us evaluate the peritoneal cavity and the thoracic cavity. The exam is designed to answer one main question: is there free fluid where it shouldn't be? We will look for both intraperitoneal and intrapleural free fluid. In a trauma setting, free fluid is assumed to be blood until proven otherwise. In supine pediatric trauma patients, blood follows gravity and collects in dependent spaces. That's why the FAST exam focuses on Morrison's pouch in the right upper quadrant, the first and most dependent space in children, the splenorenal recess in the left upper quadrant, and the pelvis behind the bladder. This is the most dependent place if the patient is standing upright. Let's use this slide to discuss a bit more about where fluid would collect in the abdomen because it can be confusing to understand at times. Say, for example, that the patient that you're seeing has left upper quadrant pain and you're nearly certain that the spleen has been injured. The most likely place to see free fluid in a child will still be in the right upper quadrant. The next most likely place will be in the pelvis, and then finally, depending on how much blood is in the abdomen, you may see some blood in the left upper quadrant actually near the spleen. The first step in performing the FAST exam is deciding which transducer to use. The top probe on the screen is the phased array probe. It's a really nice probe to evaluate for free fluid in the thorax, particularly for cardiac evaluation, because it has such a small footprint and can maneuver between the ribs. The second probe on the screen is the curvilinear probe. It's another option for free fluid and is also appropriate when evaluating for pneumothorax. However, its footprint is quite large and may prove to be too big for thorax use in pediatric patients. Finally, the last probe on the screen is the linear array probe. It can be used when trying to get high-resolution images of the thorax to evaluate for a pneumothorax. It won't really provide the penetration that you need to evaluate for free fluid in the abdomen. Therefore, when performing a FAST exam in the trauma bay, it's best to use the curvilinear probe, the probe in the middle, in order to get the best potential views of free fluid in the abdomen with the largest footprint. And you can always convert to using the linear probe if needing more detailed views in the thorax, for example, if you're looking for a pneumothorax, or you can convert to using the phased array probe if needing more detailed views of the heart. Let's briefly discuss a couple of different protocols for the FAST scan. We have a 4-view protocol, which is the classic trauma FAST exam. The 4-view protocol is only an intra-abdominal evaluation, with imaging of the right upper quadrant, the left upper quadrant, the suprapubic space, and the subcostal cardiac view. The EFAST, or extended FAST protocol, the examiner uses the 4 views of the traditional 4-view FAST exam, but also looks at each hemithorax for evidence of pneumothorax or hemothorax. First, you'll slide your curvilinear probe up from the right upper quadrant, then the left upper quadrant, to view the base of the right and left lungs where they meet the diaphragm, a view that is particularly helpful to see pleural effusion or hemothorax. Then you can further evaluate the lungs by sliding the curvilinear probe up to the thorax at the mid-clavicular line between the second and third ribs bilaterally to evaluate for lung slide and rule in or out pneumothorax with this view. We can break down the FAST exam by looking at each view independently. In the right upper quadrant, as mentioned earlier, Morrison's pouch is a potential space between the liver and kidney, and it's created by the peritoneal membrane's reflection from the inferior aspect of the liver and right kidney. The liver acts as an acoustic window, so we can see free fluid well. Remember that fluid here doesn't tell you what exactly is injured. As mentioned earlier, a splenic injury in the left upper quadrant could result in fluid actually collecting on the right side. Here's how to do the FAST exam. For the right upper quadrant view, the probe is typically placed in a coronal view with the probe indicator towards the patient's head. The anterior axillary line is usually a good starting place. Note the sonographer's probe position for the right upper quadrant exam. Here we're using the curvilinear probe. With the probe held like a pencil, the sonographer has the ability to rock or rotate the probe. You can also hold the probe underhanded with your knuckles on the bed if the child's anatomy is more posterior. Important consideration of the right upper quadrant exam is that because the liver is such a large acoustic window, the examiner can scan the patient from several different probe placements and still get a suitable view of Morrison's pouch. In the right upper quadrant, you should clearly identify the liver, the right kidney, and the potential space between them, the Morrison's pouch. Here is a video of a normal right upper quadrant scan. An important trick to this exam is to recognize that you're looking at a retroperitoneal structure, the kidney. With that in mind, if you angle your probe only intra-abdominally, you won't see the kidney. You'll see bile gas, or in this case, the IVC. How can you address this? Well, you can angle the probe more posteriorly. By angling the probe towards the patient's back, you can establish a clear right upper quadrant view that includes Morrison's pouch. Again, if you don't see Morrison's, angle the probe toward the patient's back. It is essential to visualize a number of potential spaces as part of a complete evaluation of the right upper quadrant: the pleural space, the subphrenic space, Morrison's pouch, and the inferior pole of the kidney. Another way to think about it is to think about which organs are in the region that you're scanning and to make sure that there isn't free fluid above them, below them, or in between the organs themselves. So in the right upper quadrant, make sure there isn't fluid above the liver, below the kidney, or in between the liver and the kidney. In this video, which is a normal study of a coronal view of the right upper quadrant, notice those four spaces mentioned: the pleural space, the subphrenic space, Morrison's pouch, and the inferior pole of the kidney. In contrast, free fluid will appear as an anechoic strip, in this case between the kidney and the liver. This is free fluid in Morrison's pouch. One characteristic of free fluid is that it appears pointy. It inserts itself in the potential spaces around bowel and organs. Here is a video of this pointy free fluid. In contrast, intraluminal fluid is rounded. Here's a great example of pointy versus rounded. The fluid in Morrison's pouch is pointy, and then the fluid within the lumen of the gallbladder is rounded. Here we have free fluid around the dome of the liver in the subphrenic space. Occasionally, this will be the only space in which the fluid is visible. And finally, we have fluid isolated to the liver tip. This shows us how important it is to visualize the inferior tip of the liver and the inferior pole of the kidney when you're scanning the right upper quadrant. Next, we'll consider the left upper quadrant exam. As with the right upper quadrant, we're attempting to examine four potential spaces for free fluid collection: the pleural space, subphrenic space, splenorenal interface, and the inferior pole of the left kidney. Just like in the right upper quadrant, you want to think about which organs are in the region that you're scanning and make sure that there isn't free fluid above them, below them, or in between them. So in the left upper quadrant, make sure there isn't fluid above the spleen, below the kidney, or in between the spleen and the kidney. However, some important points about the left upper quadrant should be remembered. Blood from the traumatic spleen injury usually is seen in the right upper quadrant exam first. Blood from an injured spleen will generally not travel down to the pelvis due to the phrenicocholic ligament, which extends from the large bowel to the diaphragm. And ultrasound is very poor at finding parenchymal injuries to the spleen. The left upper quadrant exam is more difficult than the right upper quadrant because the acoustic window is the spleen, which is very small compared to the liver. In addition, the left kidney sits more posterior and superior relative to the right kidney. Therefore, the examiner must place the probe more posterior than in the right upper quadrant. Generally, it is in the posterior axillary line. If the patient is supine, the back of the examiner's hand should make contact with the bed when scanning this area. When scanning the left upper quadrant, make sure that your hand is actually touching the left side of the bed. That's how far posterior you need to be to identify the left upper quadrant. Here's an example of appropriate probe placement: reaching over the patient with the probe as posterior as possible, knuckles on the bed. Here's a still image of a normal left upper quadrant view. Note the pleural space, diaphragm, spleen, and kidney. The splenorenal interface is indicated by the arrowheads. This is a video of a normal left upper quadrant view. Here's another normal left upper quadrant view. Free fluid in the left upper quadrant appears as the same anechoic pointy collection that we discussed in the right upper quadrant view. Remember to look for free fluid in each potential space. First, here's free fluid noted around the dome of the spleen in the subphrenic space. This may be the only location in which you see left upper quadrant free fluid, so don't forget about it. Here is some free fluid in the splenorenal space. Finally, this is what it looks like when there is fluid isolated to the inferior portion of the spleen. Never forget the inferior pole of the kidney or spleen when you're looking at the left upper quadrant. Let's move on to the suprapubic space view, the pelvic view. The pelvis is the second most sensitive ultrasound exam area in which free intraperitoneal fluid may be found after the right upper quadrant. Blood from the liver and/or the spleen can travel down the right pericolic gutter into the pelvis and create a positive exam because there is no phrenicocholic ligament on the right side of the peritoneal cavity. Compared with the other areas that we've discussed thus far, that we only obtain images in one plane, we scan the pelvis in two planes. An axial view of the pelvis is obtained by placing the transducer just superior to the pubic symphysis and angled so that the ultrasound signal is directed downward into the pelvis. Here the probe indicator is toward the patient's right side. Looking down into the pelvis from the patient's head toward their feet behind the screen here, we can see how the ultrasound signal will contact anatomic structures in the male pelvis with attention to the urinary bladder. Looking down into the female pelvis from the patient's head again toward their feet behind the screen, this diagram shows how ultrasound signal contacts the organs in the pelvis during a transabdominal ultrasound in the axial plane. In both males and females, the bladder is your landmark, and we're looking for free fluid posterior to the bladder. A normal male bladder is notable for a pair of anechoic tubular structures sitting posteriorly. These are the seminal vesicles. You may not see them in very young boys, but may come across these structures in older children or in adolescents. Here's a video of a normal suprapubic view. In contrast, here is free fluid noted in the suprapubic view, just posterior to the bladder. The female bladder in transverse is quite similar to the male bladder. In this case, however, there is a hyperechoic line from the uterine stripe noted by the arrowheads. Similar to the prostate, the uterine stripe is noted below the level of the peritoneal reflections. To see free fluid, the probe will need to be fanned all the way through the pelvis, making the bladder disappear and reappear as you fan through its entirety. This is a video of the normal female bladder while fanning through in transverse or axial plane. In contrast, this is a large amount of pelvic free fluid, with blood seen surrounding the uterus. The uterus is seen floating in the free fluid suspended by the bilateral mesoovarium. A sagittal or longitudinal view of the pelvis is obtained by rotating the transducer 90 degrees, so that the probe indicator is now pointing up toward the patient's head. The bladder is similarly situated just above the pubic symphysis in the longitudinal or sagittal plane. This is a normal still image of a sagittal view of the male pelvis. The prostate gland is marked by the asterisk. This video is a sagittal view of the male pelvis with free fluid posterior to the bladder in their rectovesicular pouch. Note the hyperechoic air collections from bowel in the area as well. In longitudinal view of a female pelvis, we see the uterus wrapped posteriorly around the more anterior bladder. The red arrows indicate the potential space of the rectouterine pouch, or the pouch of Douglas. In a younger patient, we may still see the uterus along the posterior aspect of the bladder. In longitudinal, we see the uterus wrapped posteriorly around the more anterior bladder. The red arrows indicate the potential space of the recto-uterine pouch or pouch of Douglas. The white arrows note the potential space for free fluid above the bladder. In the absence of fluid, the gas-filled bowel is immediately adjacent to the bladder wall. In this video, note the free fluid seen in the vesico-uterine space and the recto-uterine space, which is also known as the pouch of Douglas. The last fast view that we will discuss is the cardiac subcostal view. The subcostal view of the heart can provide the following information: if a pericardial effusion is present, and we can take a look at the overall function of the left ventricle. The probe is placed high in the mid-epigastrium, with the probe indicator to the patient's right, or 9 o'clock position. It may be necessary to flatten the probe out on the abdominal wall to achieve the correct angle to visualize the heart. As noted, the probe is placed in the mid-epigastrium, below the xiphoid process and pointed toward the heart, just slightly to the left of the midline sternum. The image on the viewing monitor demonstrates that the liver is the most superficial structure, followed by the right ventricle. With this view, you're using the liver as your ultrasound acoustic window. The interface of the right ventricle and liver is the optimal area to locate the presence of pericardial fluid. All 4 chambers lie within the path of the ultrasound signal. Here's a video of a normal subcostal view of the heart. Here is another normal subcostal cardiac view. In contrast, we now see circumferential pericardial fluid with right-sided collapse of the heart in this view. This is a concerning finding. The scan shows cardiac tamponade. We've just gone over all the steps of the pediatric FAST exam, but it's important to note how and when to use this exam in the pediatric population based on data and literature review. It turns out that the FAST exam performance in children is different when compared to adults. The presence of fluid does not dictate operative intervention alone. The absence of fluid does not rule out injury. Kids have more bowel or mesenteric injuries, which could not be detected on FAST exam. And many clinically significant intra-abdominal injuries in children do not produce free fluid. This is really where the FAST exam fails us in our pediatric patients. A 2007 meta-analysis proved this point. The pooled sensitivity for the FAST exam for intra-abdominal injuries was 66% for the more rigorous studies. Specificity was 95%. Simply put, the FAST exam is most helpful if it is positive. However, a negative FAST exam in isolation does not exclude intra-abdominal injury. A negative ultrasound examination has questionable utility as the sole diagnostic test to rule out the presence of an intra-abdominal injury. However, a hemodynamically stable pediatric trauma patient with a positive FAST should immediately undergo CT scanning of the abdomen and pelvis to evaluate for intra-abdominal injury. Before you start thinking, why did we just spend this time learning the FAST if it's not that helpful? You should realize that the FAST scan can play a role in pediatric trauma. A number of scenarios particularly lend themselves to using the FAST in pediatric trauma patients. Imagine the utility of the FAST exam in a mass casualty situation. If you have a positive FAST scan at a remote facility, you'd probably transfer that patient out immediately. Also, if your patient has a sudden clinical deterioration, it would be nice to know if hemorrhagic shock is the cause. One of the unique aspects of the FAST is the repeatability of the exam. If the initial FAST is negative and the patient's status changes, you can repeat it. More time may allow for more blood to accumulate. In summary, the FAST exam is quick, repeatable, and helpful in trauma. It focuses on finding fluid where it shouldn't be in dependent spaces where blood could collect. A positive FAST is significant and should always prompt escalation, consulting your surgical colleagues and ordering of a CT abdomen and pelvis. A negative FAST does not rule out injury in kids, so remember to utilize your other resources like trauma labs, trend their vital signs, and check for abdominal tenderness with repeat examinations. You can also repeat a FAST exam if needed. and you can always talk to your friendly surgical colleagues. I hope that this presentation was helpful as an overview of the pediatric FAST exam, and I hope that it will help you feel more comfortable jumping in with us in the trauma bay with ultrasound.